Well, gentlemen, thank you both very much indeed for joining us today. Very much appreciated.
Thanks for having us.
Thank you. Pleasure.
Dr. Fløisand, can you tell us what are some of the main takeaways from your paper?
It's a phase 3 randomized placebo-controlled trial in a transplant setting, which is quite difficult to do. And we've randomized 343 patients, a little less than we aimed for because of disruption due to the COVID pandemic. But at the end of the day, we met our primary endpoint, which means that there is a way of reducing the risk of developing acute graft versus host disease in the gut, and any risk reduction you can get in these patients would be of probable value for the patients in terms of reducing the morbidity and mortality. So it shows that we still can improve on the platforms that we have using the drug that we're using in this study. So I think that's probably the main takeaway.
So how can those improvements be realized?
In the study, we used a standard backbone of graft versus host disease prophylaxis with a calcineurin inhibitor, which is cyclosporin or tacrolimus, with a short course of methotrexate or mycophenolate in some patients. And then we also allowed for ATG. So we added vedolizumab or placebo. Was a randomized trial with placebo control, giving one dose prior to transplant, 1 day prior to transplant, and then after 2 weeks, and then every 4 weeks, covering like 6 months, the time where the risk is greatest for developing this disease. So that's how the study was designed, and the readout was at day 180, and then at a year again.
So Dr. Malard, how does talk us a little bit through some of the context here. What are some of the ways that one can try and prevent GVHD, and how does this work fit into that?
Graft versus host disease remains still a big issue because we still have a significant incidence of patients that will develop these complications, and in particular the GI GVHD. That is really life-threatening, and that will impair patients' outcomes with high morbidity in addition to the mortality. And with these new approaches with the vedolizumab that show some very impressive results with these reductions of the incidence of GI acute graft versus host disease, the most severe involvement, it can be a game-changing, because if we add this vedolizumab to the classical platform with calcineurin inhibitors, mycophenolate, mofetil, or methotrexate, and ATG also, we have still reductions of the incidence of GI graft versus host disease, and it will really improve patients' outcomes. So it's really key.
So what's next for you and for your team?
The field is changing quite rapidly. With new platforms coming up, a lot of people are using POST-SCI with success. It's a nice platform also outside the haploidentical transplant. Even if the event rate is quite low, but if you could reduce serious graft versus host disease even more, it would be nice to see if, can you put this on other prophylaxis platforms as well. So that would be something we'd like to consider to do.
Well, thank you both very much indeed for joining us today. We really appreciate it. It's been a real pleasure. Thank you.
Thank you for having us.
You.
Thank you so much.
My pleasure.